welcome everybody to the Mental Health Stigma Roundtable discussion series. Today is Roundtable 4, Paths to Reduce Stigma and Promote Positive Attitudes, Beliefs, and Behaviors. I am going to be your facilitator for today's discussion, but before we start, I'm going to turn it over to two folks who sponsored this event and have been instrumental in making these roundtables happen. Suzanne Feeney from the New York State Office of Mental Health and David Minot from Mental Health News Education. Suzanne?
Good afternoon. Thank you, Jim. Hi, everyone. We really appreciate you joining us this afternoon. I'm Suzanne Feeney, Director of Program Management within OMH's Office of Advocacy and Peer Support Services. We began our work on our strategic plan for statewide stigma reduction about a year and a half ago. And during that time, we've been carrying out a number of interventions and also some surveys to help us better understand the real state of affairs and some concrete opportunities to help alleviate or reduce stigma in mental illness here in New York State. For these roundtables, we have been partnering with Mental Health News Education, and our colleagues there at MHANYS have chosen and helped us really prepare for today's roundtable. This is a milestone for us because we're closing out the series with today's roundtable. And again, we're very grateful that you're all spending time with us and very grateful to our panelists. We hope you find today's discussion worthwhile, and we ask you to be on the lookout for our second special edition dedicated to stigma. And it is published by Mental Health News Education, and it will be entitled Stigma and How We Can Make a Difference. There's about 1 week left. If you're interested or on the fence around submitting an article, please kick it up into high gear because we want to hear from all of you. David, please go ahead.
Thanks, Suzanne. So my name is David Minot, and I am the I'm Executive Director of Mental Health News Education, the nonprofit organization that publishes behavioral health news and autism spectrum news. Our mission is devoted to improving the lives and delivery of care for people living with mental health concerns, substance use disorder, and autism, while also supporting their families and the professional communities that serve them. And we do this by providing a trusted source of science-based education, information, advocacy, and quality resources. In addition, we provide a platform for our readers to communicate and discuss important social issues in an effort to reduce the harmful effects of stigma in the community. You can access our free library of over 2,500 educational articles in both publications by visiting mhne.org. As Suzanne mentioned, part of this collaborative project is for us to publish two special stigma-focused issues of behavioral health news. The first one was focused on understanding the impact of stigma and features over 25 quality articles written by experts on the subject. You can view this issue online by visiting behavioralhealthnews.org/archives and click on the link for the summer 2022 issue. We will also post a link in the chat. As Suzanne mentioned, the announcement for the second stigma-focused issue of Behavioral Health News has been sent out with a call for article submissions. The theme for this issue will be Stigma, How We Can Make a Difference. We will post a link in the chat for you to view this announcement in case you might be interested in submitting an article, and the deadline is in about a week or so. And now I would like to introduce you to our roundtable facilitator, Jim Rodriguez.
Thank you, David. So before we begin our panel, there's a few things that we want to cover, some house cleaning issues. So very quickly, we just wanted to mention that when you're logging in, please use your full name when you log in. And the reason for that is we, especially if you're interested in CEs or CEUs or CMEs, just so that we can track your participation in the roundtables. The roundtables are being recorded, and the slides will be available to download at a later date, and you can find those at MHNE. There will be a Q&A at the end, so please type in your questions or chat in your questions during the course, or comments during the course of the panel discussion. And also, please indicate to whom you'd like the question addressed when you do that. And then just very quickly, our disclosure: all panelists and planners have no financial relationships to disclose with ineligible companies whose primary business is producing, marketing, selling, reselling, or distributing healthcare products used by or on patients. And then, as I mentioned, they're approved for CEUs. If you have questions, and I'm just going to go over this really quickly, if you have questions about CEUs, you can refer those questions to Karen Wagner at karen.wagner@omh.ny.gov. And then very quickly, as I said, we have to sort of talk about this accreditation. We have to show, the next one, the previous one, David. Yeah, there we go. So we just have to show this. This is our accreditation statements. We are approved for CEs for social workers, psychologists, peers, as well as CMEs for physicians. And these are some of the disclosure statements that we need to make all of you aware of. Next slide. And then as we go through our discussion today, as I mentioned already, type your questions into the chat. During the course, feel free to ask for information. If we use terms or jargon that's unclear, please ask for clarification. Be open to alternative views. We have found over the course of the first 3 roundtable discussions that there are many views around how to address stigma. Please be open to alternative views. Please feel free to share your views as we move through the panel discussion. And be comfortable with unfinished conversation, And we're going to talk later about some next steps, but what we see these roundtables as is the beginning of a conversation about what we can do to continue to reduce stigma or mitigate its effects on folks. So by definition, these are going to be unfinished conversations because there's so much more to do. Please practice self-care. Bringing up issues around mental health stigma can bring up folks. Please take care of yourselves. Remove yourselves if you need to, or take a break. And as we always talk about with new 988 services, reach out to 988 for support if you need. Challenge respectfully, and again, share your experiences, both professional, and we know we have many people with lived experience on these calls, so please share your experiences as well. And then, so very quickly, just as an introduction to the topic, today's topic, these are just some of the strategies that we know are effective in reducing stigma. Education, providing factual information and correcting misinformation about negative attitudes regarding mental illness. Mental health literacy campaigns, which are educational programs, but more and more focused on K-12 education and getting young people to understand the impact, and getting also young people to seek and ask for help and support when they need it. Contact-based interventions, that's people with lived experience of mental illness or substance use disorders interacting with the public and describing their challenges and stories of success to in many ways, dissuade people around myths and misinformation about people with mental illness. And then protest and advocacy, so identifying instances of prejudice and discrimination, publicizing them and speaking out against them. And then peer services, and I know many folks on this call and participating in these panels, but also in the audience, are peer service providers. And that's people with lived experience, being equal members of care teams to provide non-judgmental, non-discriminatory services while openly identifying their own experiences and connecting people with peers who can help them navigate and understand the systems that they're going to be involved in. And then lastly, legislative and policy change, creating new laws and policies to protect these stigmatized groups from discrimination. So these are all of the strategies, and as we know, there's a lot of research actually out there. I've come to know a lot more research than I ever thought was available on this. And we know contact-based interventions, educational approaches, peer services, the combination of those are oftentimes extremely effective in reducing stigma. Next slide. And so I just want to highlight a few themes that have come through from the first 3 roundtables we've had. So this is a little bit of a review. So in roundtable 1, this was the experience of mental health. It was a little bit of a ground setting the level and asking folks about their experience. A few themes that came through there was stigma for many people was worse than the illness. Many people who struggle with mental health challenges found that the stigma of those challenges was oftentimes more difficult than the challenges themselves. We need to go beyond changing beliefs and attitudes to changing behaviors, and specifically around changing behaviors is behaviors especially that are discriminatory and block people from opportunities. Change needs to occur in the public and in our culture. So addressing public mental health stigma is critical in our culture, our beliefs and thoughts about mental health. And then wraparound services to care are critical for all, not just children and adolescents. So we oftentimes associate wraparound services with children, youth, and families, but also for adults. And then a lot came up around substance use stigma and needing to better understand that as an illness-related stigma as much as mental health stigma is. So those are some of the themes and I should say some of the themes, there were many more. And then in Roundtable 2, the mental health stigma and diverse groups, we had a discussion around intersectionality and intersecting identities and people with mental health stigma. So what came out there, communities, religious, ethnic, racial, communicated a lack of acceptance, suggesting intersecting forms of stigma within their community. So mental health and religion, ethnic and racial backgrounds, sometimes those creating intersecting forms of stigma. And then people with mental health challenges needing to be understood in their full complexity, all the identities that they hold and all the ways in which those different communities and spaces that they live in need to be addressed in terms of support. And then we need to focus on all forms of all the isms or forms of stigma when trying to reduce mental health stigma. We can't do one without the other. Otherwise, certain groups will be left off and left out of care and achieving success in their lives. And then approaches care need to be adapted to meet the needs of diverse groups. And lastly, that mental health stigma drives people to help and reduce stigma in various communities. Many of the folks, and that also came through in the first roundtable as well, people turning the stigma that they've been exposed throughout their lives into becoming helpers and helping others. Next slide. And then lastly, in Roundtable 3, we talked about the role of the media. We had journalists available who joined us and engaged in a discussion about what the media can do to help reduce stigma. And so we focused much more on that rather than the problems that the media contributes to mental health stigma. So some media is committed to promoting mental health and wellness, but not sure how to discuss mental illness. A lot of discussion around language and how we use language to reduce mental health stigma. The media having a responsibility when they ask folks to tell their stories to be careful about re-traumatizing folks or exposing folks to trauma. The media needing to reduce stigma by reporting on affirming and strength-based recovery stories that address human complexity. And also the media needs to adhere to standards for ethical reporting. For example, not pairing mental health and mental illness and violence by mentioning mental illness when it is not relevant to the story. So oftentimes that's something that we know that the media can oftentimes do. And then the media must hold systems accountable by going beyond personal mental health angles to tell stories from multiple perspectives. So when we are talking about people who have mental illness and the difficulties, oftentimes we know the stories behind that are failures among multiple systems in housing and vocational services or social services that are needed as well. And then just a few overall themes that have come through are high registration counts. And so we have many people who've registered for these roundtables, obviously indicates an interest and a commitment related to reducing stigma, that people with lived experience and their family members have to be central to the process of understanding stigma and also reducing its effects. And then stigma reducing efforts, they have to consider and address all types of stigma, internalized stigma, public stigma, anticipated stigma, and institutional, structural, and systemic forms of stigma as well. And then we must understand and address how mental health stigma intersects with other forms of stigma, as we mentioned already: race, gender, age, sexual orientation, religion, and region. And then we have to focus on telling stories about people with lived experience as complete, complex, and normal human beings. And so those are many of the themes that have come out. So with that as a backdrop, I'd like to sort of transition into our panel. Before we get into the panel, though, David is putting into the chat a link to a word cloud. which we'd like you all to participate in. And in the word cloud, what we'd like you to do is try, in a word, it could be difficult, in a word, what are some possible solutions or actions we can take to reduce stigma? If you can try to use it, just one word to describe what are those things. We'll come back to the word cloud later and revisit it, but please feel free to join us in that word cloud activity. Words or solutions or actions that we can take to reduce stigma. Okay, and then with that said, let's get into our panel discussion. So today on our panel, we have an amazing panel to talk about next steps and future directions. We have Glenn Liebman, the CEO of Mental Health Association of New York State, MHANYS. Harvey Rosenthal, unfortunately, is not able to join us today. He is ill, but hopefully he's in the audience. And Harvey, we wish you well. Dr. Angelia Smith-Wilson is the Executive Director of Friends of Recovery, New York, for New York. Euphemia Strauchn is the CEO of Families on the Move of New York City, Incorporated. Daniel Tanh is the Executive Committee member of the New York Coalition for Asian American Mental Health. And Rabbi Simcha Weinstein is the DEI coordinator for Families Together in New York State and the founder of the Jewish Autism Network. And then we also have two incredible researchers joining us who will be responding to the panelists at the end. Helen Maria Elena Lecas, Dr. Maria Elena Lecas from the Center for Research on Cultural and Structural Equity at NKI, and Dr. Phil Llanos. He's professor at John Jay College of Criminal Justice, University of New York, Psychology Department. Both are experts in mental health stigma. Okay, so turning to our panel now. So for our panel, the first question that we want you all to sort of address is in your organizations and the work that you do, and just for the audience, all of these organizations are dedicated in many ways to addressing and reducing stigma, among the many other things that they do, but it's central to their mission. So for all of you, for each of you, what are the current efforts or initiatives? What approaches to reducing stigma are you taking within your organizations? And we'd like each of you to respond. And Dr. Angelia Smith will be the first, Smith-Wilson, will be the first to share.
Thank you. Good afternoon, everyone, and welcome to Roundtable 4. I feel like so much has already been discussed. So I'm over here moving stuff out of my notes, putting stuff in my notes and all of that. So bear with me. I have the great opportunity of serving as the Executive Director of Friends of Recovery New York, which is a network of over 40 agencies in New York, all doing recovery services. So we are doing, as was the first screen that James shared with regards to all of the various approaches to addressing stigma, I would probably say our area is it's all of those things, right? It really depends on who our audience is and what is it that we need to be doing. But I will just focus on policy. Because we feel that is really at the heart, policy that wraps around individuals in our population is really at the heart of where we feel we can make the most change, right? Because we want those policies to be able to have a direct impact on the individuals that it is initially designed to create. So one of the efforts that we have for New York, very, very simple. A combination of education and policy and legislation, and just put plain old common sense is humanize. We are very deliberate about humanizing the issues that our population face, that being SUD as well as mental health concerns. And we understand that sounds very simple, right? And folks like, yeah, of course, but where does that get you? For us, it's really about being very deliberate about understanding the art and science of the messaging, and to ensure that humanity piece is so much ingrained that it evokes something in the individuals that we're trying to have and engage in dialogue about improving the conditions of folks in recovery, or the issue of SUD, or the issue of mental health, right? And I'm very careful not to say evoke some feeling where people are going to automatically say, I have to do good. But for us as advocates, evoking any type of response is what we are really going after, right? And so by humanizing, we oftentimes will put a very deliberate face, right? We all know that stigma puts faces to issues, right? Our job is to remove that image, that composite, that face that society has said, this is the face of this, or this is the face of that. Our job is to remove that face and put the face of a family member, of a loved one, right? Of your neighbor, whoever, right? To be very purposeful so that when we engage in having a conversation with you around recovery efforts, SUD efforts, mental health efforts, we are not having a conversation with a ghost. We are having a conversation with you about your Aunt Millie or your cousin Brenda, or whatever the case may be, right? So we're very deliberate about that. And one of the other things that we do too is for us around, primarily we talk about addiction. And we talk about addiction being a public health concern. So we move away from a lot of the negative perception that is associated with addiction, right? So it's kind of like a twofold attack. We remove that face, right, that you have attached to that issue, and then we also put that issue in something that is easy for you to absorb. We don't minimize addiction by comparing it to other physical conditions. We just simply put it there for you to have an alignment, for you to have an understanding, for you to have a perspective about something that is a public health concern that you may have not thought about it as a public health concern. So those are some of the things that we are very deliberate about doing with Friends of Recovery and all of the partner groups that we work with and all of the coalitions that we sit on. So if I had to put it, which I had to put it in a 4 to 5 minute answer, it is really to humanize it in a way that we build allyship that is deliberate, that is purposeful, and that is driven by a strategy that moves and evokes in folks. So.
Thank you, Angelia. And Dan, I'd like to turn it over to you.
Thanks, Jim. Hi, everyone. So, with the New York Coalition for Asian American Mental Health, we really strive to think about really improving the quality of services in Asian American communities throughout New York, really thinking about unmet mental health care needs and service disparities across the Asian American population through advocacy, community service, professional development, and collaboration with government and local providers. And so the first piece to understand is that mental health and social justice are intricately connected. And so a lot of this really means that if we're considering Asian American, Pacific Islanders, we need to consider the impact of racism on mental health, because racism, for example, is dehumanizing, right? We just talked about a lot of humanizing, it's dehumanizing. Racism is dehumanizing. And a big part of that in our work is what I like to call expansion, right? Expand what it means to be American, expand what it means to be Asian, expand what mental health means away from this idea that it's just about professional mental health service utilization, but really about the ways that people have been taking care of their mental health for generations, including through creative and other forms of healing. Expanding access to mental health services when those professional services are needed. And part of that expansion is understanding that we need to advocate for what's not provided for us within the institutions we occupy, including at the agency, city, state, and federal levels, right? And that's why advocacy groups emerge. So for us as an all-volunteer organization, the big piece is this idea of coalition building to address the multifaceted aspects of what contributes to mental health, and this idea that mental health is political. So we have in the past submitted information to the Department of Health and Human Services, Office of Minority Health, to advance culturally affirming care. Recently organized discussion points for City Council convening on mental health within Asian organizations throughout the city. We've sent in recommendations to the Council for Social Work Education, which ended up accepting some of our recommendations for anti-oppressive practices. And even historically, our organization was founded to push for Asian bilingual bicultural services, which resulted in lobbying that led to what I believe is the first Asian inpatient unit in the city in the 90s, when I was a little kid. And part of this is the heavy need for expanding language access, right? I'm born and raised in the US, so, language isn't an issue for me. But it's such an underemphasized issue, right? 2/3 of Asian Pacific Islanders in the US are foreign-born, last I read. I don't know how many of them have English as a second language, but if mental health providers cannot read, write, or speak in ways that match the diverse Asian diaspora, there's no way that people utilize professional mental health services. So then on the other hand, internally, we build community across mental health and community wellness professionals who are part of this diaspora. Professional development among ourselves is really key because there's not many people like us, right? Asian mental health providers are limited. And so we founded the first Asian American peer supervision group in New York City, as far as I know at least, to really provide a space for all of us to give one another the support we need around issues that we have all internalized, right? About wellness, about systems of oppression, that's unique to us. And so because we're a coalition, we have members across New York City doing amazing work with many opportunities to partner, ranging from educational workshops, healing circles, community outreach, and culturally relevant and immigrant specific contexts. In the past, we also held suicide prevention education workshops to help people recognize risk behavior and understand the mental health factors that lead to reducing stigma. And so I also want to say, I think our attendance to the increased incidences of anti-Asian violence and subsequent visibility of anti-Asian racism, which has existed throughout all of American history overall, is a huge part of how we operate. So what wellness promoting strategies can we engage in that also explicitly focus on anti-racism? That's really how I think we try to engage in our strategies.
Thank you, Dan. And I'm seeing a theme developing clearly so far. Multi-prong approaches, just multiple level approaches. Thank you. And Euphemia.
Good afternoon, everyone. So I am Euphemia Strauchn. I'm the CEO of Families on the Move of New York City. I am the family member of those who have received services. I'm a former recipient of services myself and systems involvement. And my agency is a grassroots agency that was started by family members who had children that had been through the children's systems, child welfare, juvenile justice, foster care, substance use prevention, mental health, special education. And we came together to start this agency to provide support to families that are often considered as a problem. And so in our work around stigma and reducing stigma, we want people to know that we're not a label, that we are not what you see. You have to get to know us, because so often the perception was, oh, you're just a parent. Oh, your child has problems and you must be the reason why they have these problems, which is something that we've had to fight against forever. So when we look at combating stigma, we have to change the perceptions of how families are perceived. So that is the work that we do at my agency. Family advocates are parents and sometimes have also received services. Their children receive services. The youth advocates are young adults who have been through the systems. My programs are co-located in the New York City Children's Center, South Beach Psychiatric, Astor Children and Families in the Bronx, and 3 community residence programs for Jewish Board. And we're at the RFK, and we're at Girard Avenue. And then we have the training center, which is located in Staten Island. So when we look at where my programs are located, we're located where the highest level of need of children are in the hospital setting, whether they're inpatient, day treatment, clinic, they're at the higher level of needs of services. So when that happens, we have to be mindful of the interaction between the provider and the families and the youth. So when we started the agency, we started out as information and referral, but we realized that it takes more than that. But one of the things that we found that we consistently have to do is educate people about us, about our needs, about our children's needs, about how we're approached, and to help people feel comfortable talking about what's going on, because so often parents feel guilty, they blame themselves, and it doesn't happen, it often happens like in the past where providers also blame the parents. So we work to educate providers through trainings in collaboration with the Office of Mental Health. We provide trauma and recovery training for all of their new employees, and we commingle the groups with staff from peer support. We also provide trainings in the community. And the whole goal is really to help people understand that stigma doesn't help anyone, it hurts everyone. And stereotypes are a segue to stigma, right? So wherever you see a stereotype, you're going to see a stigma associated with it. And our role is to really educate people, to break down those barriers of not understanding about certain groups. It's like cultural competency or cultural understanding and responsiveness, right? And a lot of it is based on the fear of not knowing. So we really work on communicating and talking about mental health and wellness openly, and also substance use. And we realize the importance of language, because often people are treated a different way depending on how you identify them. So for example, I know Dr. Angelia talked about substance use, right? If you say someone is a substance abuser, you're going to treat that person different than you say who is a substance user, right? And if you say someone has mental illness, you're going to treat them different than you say someone who has mental wellness challenges, right? So we really work to wordsmith language. It's very important, because what often happens is that people are identified by their diagnosis and not as an individual. So when we look at our approach, we understand that data is important. However, data and statistics are just numbers thrown at you with the graphs and with the numbers, but it's dehumanizing. But when you hear someone tell you their story and share what they've been through, and this is how it makes me feel when someone refers to my child like this, how it makes me feel when you refer to me as just a parent, or how it makes me feel when you say, I don't care about my child because I'm choosing not to come visit my child right now because I need a break. I've been living with this child who has severe mental wellness needs, right? And sometimes you just need a break. The family needs a break. And it's not that I don't care about my child, but it's about self-awareness and self-care. So we bring a different lens to the table through our trainings to the community, our partners in the community, and to the families that we work with, because we help them to see the light at the end of the tunnel. Because what they see is that if you see this youth advocate helping someone, and you see the family advocate helping someone, they say, you know, I was in a similar situation to you. It seems like there's no light at the end of the tunnel. However, if you stick with it, with the right supports, and you rally those people around you that care and that are willing to provide you the support with no strings attached, no labels attached, there's nothing that you cannot accomplish. So when we look at it from that standpoint, we really encourage, not only through trainings of the community and the families and the providers of services, but we also communicate to the families themselves that you don't have to answer to anything, right? People can't control who you answer to. And you can command respect just by how you are and your level of advocacy for what you and your family needs. And so with that said, we really promote education, education, education on multiple levels. And when necessary, calling people on their stuff. Do not co-sign with somebody who's making inappropriate comments about someone with mental wellness challenges. Do not make inappropriate comments about someone who's on substances, because trauma is a hell of a thing, right? And it can impact anyone. And I'm sure on some level, we have all experienced some type of trauma. But also during this time, I think the doors are really open because COVID broaden the playing field, right? Because one time it was just those people who had mental wellness challenges, but now anybody, we knew that it was anybody that could be touched, but now people are aware on a larger spectrum that anybody can have mental wellness challenges. And so it's really helpful to us that the entertainers are coming forward now, sharing their stories. Thank you.
Thank you, Euphemia. And Glenn.
Thank you, Jim, and thank you, Suzanne. And Euphemia, I mean, I just, as someone who's a parent themselves, also, director of an organization, I feel exactly the way you felt in many ways, the dehumanizing piece as a parent being blamed somehow, some way for your kids' mental health issues. And it's very, very frustrating. I come from the NAMI movement. My first job was I was ultimately the director of NAMI. And I go back to the days of where they talked about schizophrenic mothers. I mean, it's so absurd to think that, that mothers somehow cause their loved ones schizophrenia. And yet that was, until the 70s, 80s, that was common theme. So we still have a long way to go. Thankfully, we've come a long way, but we still have a long way to go. And I'm so glad you brought up the issues you did. So my name is Glenn Liebman. I'm the longtime director of the Mental Health Association, New York State, commonly known as MHANYS. We have 26 affiliates in 52 counties. And what we mostly do is we provide community-based mental health services, but we also do a lot of advocacy, education support throughout the various communities. And I was struck when Jim put out the slide about the different pieces around stigma and kind of the different themes, and I was struck by two of them, which are really consistent with our themes in our agency. One is the mental health literacy campaigns, and the other is the legislative piece. And so we've spent a lot of years, again, anti-stigma is in our mission. So obviously we spent a lot of time working on this, and we've looked at various themes over the years. How can we break through in stigma, and even basic things like, we had a mental health tax checkoff. If you look at your income tax forms, if you see tax checkoff, you see all these things for Alzheimer's, you see all these things for, cancer prevention, all the appropriate things, but there was nothing ever about mental health. So we fought for that. We have a mental health license plate, do a lot of advocacy around. Same thing. It's like you have all these other disease things we're talking about. Why are we not talking about mental health issues as well? So we put that on the platform. But the big thing we've really put on the platform, and it's twofold. The big thing we've really moved forward with is around mental health instruction in school. New York State proudly in 2016 became the first state in the country to mandate the teaching of mental health instruction in schools. And that was a really big deal in the sense that it created, yes, you could do technically to get around the law, you could do a one-off, you could go and identify a health teacher, and a health teacher can go into one class around mental health mental health prevention, anti-stigma, and that's great. But what it did was it helped to change the climate and environment of schools. To the credit of the New York State Office of Mental Health, Commissioner Sullivan and the SED commissioner, they formed a coalition with our organization to go out and identify solutions. And we were able to help to change school environments. And again, using the approach around mental health literacy, talking about this much more about mental health awareness and not identifying the 1 in 5 kids who had a serious mental health issue. It was about a holistic change. So that's one of the things that we continue to do. We continue to have a school mental health resource center that's doing great work in their communities. And again, we're very proud of that. And we look at that as kind of like when you go into schools, that's your first line. That's where you can go and you can begin to erase the stigma that continues to be out there. And I'll talk about that in a second. And the other thing we just wanted to talk about, and it was touched on as well, is family engagement. Again, as a family member myself, I've seen this from so many different angles, having been, at NAMI, having worked for the state, having been now with the Mental Health Association the last 20 years. I've seen that. So it's such a struggle for families and for peers, and family members are so long neglected by our system of care. It's like their voice doesn't really count. They're looked on as like, oh my, yep, it's like they get a lot of lip service. So we have a program within our organization that we're very proud of. It's called the Community Partners. And basically, it's been funded through the Office of Mental Health. And it's a whole health approach. It looks at the individual and it looks at their family and it brings them together. And their family could be defined as anything you want. It could be your close friend. It doesn't have to be a specific family member, but you have these engagements where you identify the strengths of each individual and their loved one. It's as the founder of the program, Deb Faust, says, it's not an isolation. Recovery is not an isolation of others. Recovery is about working together as a family unit and recognizing the role of the family members and the role of the peers. And that's significant. So those are a few of the things we're doing, but I just wanted to step back for a second and I'll get to more when we talk about the obstacles and struggles. But, right now we're in a dichotomy. I look at this and say, we're in a real dichotomy here in terms of issues around stigma. Because again, we're in schools and we can tell you that you go into schools and the greatest hope for our future is the young people. Young people they don't look at discriminate. They don't look and say, oh, this kid has bipolar disorder, or this kid has depression. They're not labeling. They're just the opposite. And especially post-COVID, they're looking at this and they're saying, we get this. We totally understand mental health related issues. And there's almost no stigma, which is such a change over there. Obviously, I'm a person in my 60s, but even people in their 20s, 30s, it was different. So it really is a remarkable change. But yet, here's the dichotomy, and Jim, you touched on it a little bit. Here's the dichotomy is that we still have, and I wish I attended the media one, I didn't get an opportunity, because we still have that stigma about when somebody does something violent, it immediately goes to mental health and mental illness. It's like an immediate trope. We go into this, dialogue and discussion that this person, well, the top shooting in Buffalo or the subway pushing in New York City, well, the person clearly had to be mentally ill. So let's lead with that. And that is so stigmatizing. And ultimately what it does is it stops people from seeking treatment because they need that treatment. And yet they're going to be like, oh my God, I'm going to be conflated with people who are violent, who push people on subways. I mean, it's ridiculous. So we have to get to the point where we're talking about this at a young age, where we're, again, very early on in life, where people are having this discussion, preschools, where we're really talking about identifying the strategies that can be utilized so that ultimately we don't have to deal with an adult system of care where there is so much stigma that continues to exist for so many adults in our community. And I could go on for 4 hours. Harvey's a good friend of mine. I feel like taking up his space, but I will.
Thank you. Thank you,
next folks. Yep.
And I really appreciate you highlighting, focusing on young people. Their attitudes and beliefs oftentimes are much more malleable than adults. And there's a lot of research showing that those efforts really do have high impact.
Yep.
And so turning it over to Simca, Rabbi Simca.
Thank you very much. I am the DEI coordinator at Families Together. I'm a advocate and I'm also a rabbi. So it is about to get biblical. Professionally, I've been trying to reframe the conversation around community engagement. Mental health professionals can often portray communities as monolithic entities. Otherness does not always equal homogeneous. The culture is complex. We often try to reduce culture to music, to food, to clothing. My community may dress black and white, but its adherents are anything but. And our current model for cultural competency can often be drilled down to providers being forced to watch a training video, sometimes at double speed, I've seen that, just to check a box. So when I'm training peers, I've started to shift the conversation to cultural humility, and the dialogue can change the dynamic of community engagement. That when I'm recruiting peers, I also find it important to have peers from within the community in which they're working. That can make clients feel more understood. It's a good start. However, we have to know that choice is also essential, and many worry about confidentiality and name recognition. I also like to push the boundaries. So personally, I have found over the years that the first point of contact for many seeking help with mental health or substance use challenges are faith leaders like me. And that while my faith community, I'm not recruiting over here, can offer many good things, however, insular social dynamics can produce guilt and shame over a perceived failure to conform to communal expectations. Treatment can be seen as crossing a social boundary and may even require the permission of a faith leader. Marriage prospects may even be harmed. As a veteran community rabbi, campus rabbi, hospital chaplain, family peer advocate, father of a child on the autism spectrum, and last year I was diagnosed with ADHD. Apparently, I'm the last person to know this because everyone I tell this to said, "You didn't know?" I'm like, no, I really didn't know. I've kind of gleaned a powerful patchwork of mental health literacy. I've got real world experience in cross system settings. However, I think we need a more formal effort to train clergy, to train youth ministers in evidence-based mental health and substance use interventions. Simply by acknowledging that there are mental health challenges, faith leaders can reduce stigma, shame, isolation. I highlight the great work of Pastor Mike in Harlem, because ultimately we can't pray away neurodiversity, but we can use our pulpits to preach and to teach. Thank you.
Thank you, Rabbi Simcha. So I want to turn now to our discussion about the future. And I have to just say that some of the themes that are coming through here is obviously, as I mentioned earlier, this idea of sort of multi-pronged approaches, really hitting all of those approaches we discussed earlier. And it seems like you are all doing that, hitting it from multiple directions: education, mental health literacy, contact-based work, legislative work, peer work. I want to switch now. So, and I'm realizing we're a little bit limited on time. So I want you to sort of think about, what are the challenges? What do you see? And I'm going to limit you to what you think might be the one biggest challenge we have, just for the sake of time. What's the one biggest challenge you see in moving things forward? And I also say that because I think you've all provided hope through describing your efforts, but also, thinking a little bit about, what are the challenges that you face moving forward? Angelia, you want to start us off?
Yes, I think that as I think about all of the kind of intersectionality of all of the things that folks said about some of the solutions, one of the things that always stands out to me is really kind of it's looking at the individual, right? We know all of these kind of global approaches. We know all of the advocacy, the education, and all of that thing. But one of the things that really strikes me sometimes as I'm engaging in all of these is really that individual look at yourself, getting the private and the public self together. I sit and I talk to people all the time and they tell me, oh, I care about this, I care about that. But then when something happens that just shocks us to our core, like the violence in Buffalo, folks automatically kind of easily go there, right? And so if you go there, can you imagine how even how others go there? So I offer amnesty to individuals who are struggling themselves with understanding how they develop a personal strategy to use themselves as an advocate in the full sense, not in one that sits in rooms and carries signs, but an advocate, one in the true sense, that has their public and their private self together, right? So that we can authentically and in a genuine fashion practice what we preach, right? And so that's what I would offer is a campaign where we just say, listen, get that private and public self together, because people do not do that enough.
Just to clarify, Angelia, when you say that, do you mean people with lived experience coming out and being clear?
I mean, people with lived experience, because there's a lot of behaviors within the communities that's kind of that intrust stigma that happens within communities, that they continue to perpetuate overall stigmatizing behaviors, right? They look at one group of individuals that may be addicted to a certain substance different, right? They look at one mental illness that they see as more psychotic in nature, right? So stuff like that. And I also say that to not only folks that are within the community, but that folks that are champions and allies of the community as well. Because when you're half in, we can kind of, that's why policy is not supportive enough, right? Because there are a lot of critical conversations that should be had that can't be had because individuals have not gone there themselves.
Thank you for clarifying. Glenn, I see your hand up. Yeah.
Thanks. That was so well said, Doctor. Really, it's so true. One of the things that there is a strong connection here, and it's about stigma. It's about stigma of our workforce. Our workforce is incredibly underpaid and undercompensated for the work they do. And that manifests itself in so many different ways. It can manifest itself in terms of long waiting list, housing, waiting months for housing, we all know that. And we all know that the major reason why is we have a crisis in terms of our workforce. And until we address the crisis of the workforce, everything we talk about, all the anti-stigma efforts, all the work we're doing kind of is not, it's incredibly important, but we need the workforce to be able to provide the support and the expertise and the knowledge. And I'm talking clinical, I'm talking paraprofessional, I'm talking direct care workers. We need to be able to pay those people a significant rate, a cost of living adjustment that is higher than, look, the governor put out an incredible budget, no criticism there at all. I think it's great, but we need to respond through a cost of living adjustment that moves much higher than a 2.5% increase. And I can get on my high horse about that. And I don't want to get too political, but the bottom line is we cannot provide all these wonderful programs and services in anti-stigma efforts without the workforce that's essential to the recovery of an individual.
Thank you, Glenn. Dan.
I think there's this kind of idea that individuals change faster than systems. And so what can individuals do to advocate for changes to systemic norms, right? So if we actually consider ourselves within that systemic perspective, we are really disempowered, right? So if we think about this mental health delivery system versus the physical health delivery system versus the food system, the education system, housing, financial system, it's all inherently disempowering. And therefore, things that worsen wellness. And so we really need people who have the power to change things by doing concrete things to make it easier to consider the full spectrum of what supports mental health across the diversity of, for us, our AAPI community, including making it easier to have bilingual clinicians, visas, pay parity, actual collaborative care across disciplines, right? Teachers, schools, leadership, education, employment systems. How can government organizations directly increase both social and financial capital to make it easier to intentionally and explicitly address mental health needs defined by our communities, right? So we talk about stigma, and stigma is a huge deal in preventing access, but there's also a lot that our communities are already doing to improve our mental health, including, through coming together the past couple of years to overcome collective trauma. And so there's this recognition, like our communities, we have strengths, including in our immigrant communities, and understanding that being culturally relevant to our communities means acknowledging that's what's happening now is prioritizing culturally relevant care to who's dominant in our population. And I'm not talking about AAPI communities because we're not dominant in American society and we have multiple layers of oppression. So ultimately, for those whose role it is to support mental health, whether at the city, agency, state, federal level, power really needs to be shared with the full diversity of the Asian American Pacific Islander community to really have our families and neighbors drive and guide the shift towards community wellness rather than just individual wellness.
Thank you, Dan. I want to bring it Simca or Euphemia. Any?
I-
Simca? Go ahead.
I'm going to be a little subversive because you told me I could, Jim. So I'm holding you to it. I know this is the positivity panel, but I have found positivity itself to be a form of stigma. In our journey, in our lived experience, it feels like at times there's this like implicit command to be positive all the time, where really you just want to talk freely about the challenges you're facing. And marketing content that providers put out is sort of overtly upbeat, feel-good sentimentality, sometimes sponsored by hedge funds, and sometimes it can feel at the expense of reliable help. And I have found, and I know that I speak for other parents and self-advocates, that we at times find awareness and inclusion kind of annoying. Sometimes it feels like everyone I know is wearing Lycra, doing a triathlon about topics that I'm really very aware about. So just to be aware of someone's existence can be a form of ableism. We'd rather have accessibility than awareness. People tell me all the time, I'm so brave. Well, you're not brave when you don't have a choice. And my kid's not that special. All my kids are special. And I have noticed that also as a parent myself, I have to really be careful when I'm talking around self-advocates. Sometimes I'm talking, about you, in front of you, about treating you. That's not appropriate at all. And I've learned a lot from self-advocates regarding sort of ableism, self-stigma, feelings of shame, inferiority. And I think what we need is an affinity space like this, where we can build bridges with self-advocates, parents, providers to promote understanding and collaboration. Thank you.
Thank you. Thank you, Sim. And Euphemia, I'm going to let you have the last word before we move on.
Okay. So I'm going to put my foot in the water right now. And I'm going to say that the challenges we face in reducing stigma has to do with the interconnection between stigma and racism. We try to, say get over it and push it under the rug, but the more we push it under the rug, the higher the rug is getting. So the higher the rug gets, the more we trip over it. And it keeps coming back into our face. We do a couple of, webinars or whatever on how not to be, not to have racist practices and systems, but it is what it is. And words and language, imagery have been very harmful to Black people. When you watch the television shows, when you watch cartoons, the image portrayed is always of someone who's a criminal, who's a rapist, who's a drug dealer, who's anything but a child of God. Now, I'm going to say, I'm a first lady elect to the to the rabbi there. So the thing about it is, change takes time, and it is said that change takes a generation. Well, how long is a generation now? Because it seems like the further we go forward, we're taking 2 steps backward, right? And every time we think we're getting ahead, something changes. So when I was growing up, there was a saying, sticks and stones may break my bones, but names will never harm me. That is the biggest lie anyone could ever tell, because there's an ancient saying that life and death are in the power of the tongue. Once you put a word out, you can't take it back, right? And then dependent on the mindset of the individual to whom that word is spoken, it can be taken in and personalized, or it can bounce off. Unfortunately, when we're talking about people with mental wellness challenges or people that have substance use challenges, those words stay inside and feed those demons of mental health challenges and those demons of substance use. And we have to get on board that, no, it's not going to be okay anymore to show these projections, to make these statements in cartoons and movies, and even not just about mental health, but about health. Because you watch these programs and you see little children with asthma, they always make them seem like wimps, right? If you watch these movies with children, they have the pump, and they always these children that can't do anything. Or they show a child who's overweight, right? And is always eating. So they feed those stereotypes, which turns into stigma. So we have to stop with the lip service. What I am happy about is that I heard last night that the James Bond movies are changing and they're editing their movies to take out inappropriate things that are no longer appropriate. So that's a step. So maybe other movie producers, right? Or people who are doing cartoons or whoever's in the media may follow suit. But that's one step. But it's also up to us that when someone is using inappropriate terminology, that we call them on their stuff and just say, that ain't cool. That's not right. So like I said before, the squeaky, it takes time to make a change, but the squeaky wheel is what gets what's needed. So we just have to be squeaky wheels.
Thank you, Euphemia. So I know that probably just covers the surface of some of the challenges we have. So but again, in the interest of time, I'm going to switch to our researchers and their response. And I'm going to start off with Phil and your thoughts about what you've heard from the panel today. And actually, Maria Elena is also going to do a little bit of an overview of the themes that have come through across these four panels. But Phil?
Sure. Yeah, thanks for including me on this as well. And I want to apologize for things that I'm not able to include in my summary, because I've been trying to take notes and connect the themes that I'm hearing people say and connecting them to kind of the larger mission of the statewide initiative that this is all part of. So some of the things that I wrote down that I'm putting together, across these things are, number one, I took note of Glenn Liebman's statement around the school-based intervention that Mental Health Association advocated for, and that's happening. And I'm a parent of, I have a public school graduate and one who's currently in public school here in New York State. And what I think is missing now is a standardization of that. My older son, when he was in student government, I told him about ending the silence, that we'd done some research on it. It's NAMI, based contact, stigma program, and he advocated for it to be introduced in the school. But it's not really happening unless someone in a specific school is advocating for it. And our research around ending the silence shows that, it has a short-term impact, that it doesn't sustain. So what schools really need to do is they need to introduce these research-based supported packages like ending the silence in middle school, and then I'll package that along with extended discussion. All of our schools have advisory classes where students have the opportunity to talk about these things, but we don't have standardized approaches to really make sure that they're making use of that opportunity for students to learn about mental illness and be able to speak openly about their own challenges and those of their peers. So that's something that stuck out to me. We also heard a lot about legislative changes. We have here in the state of New York, we have discrimination that is written into our laws. There's family laws that have overt discrimination in them toward people diagnosed with mental illnesses. We need to get that out of there. We also need to use legislation to address some of the pay issues that were brought up by some of our panelists as well, that basically the field of mental health service is stigmatized in its status as a low status occupation. We have high rates of turnover as a result of that. Many people were speaking about media as this is something that's very harmful. And I took note of Euphemia's statements around language and how impactful this is, certainly in terms of racism and also in terms of stigma towards people diagnosed with mental health conditions, and that we need to develop standards that we clearly communicate with our media outlets across multiple levels, social media, print media, televised media, to really make it clear what our expectations are around the kind of language that's appropriate. Clearly, there was a theme around cultural competence and intersectionality, and that you can't separate stigma from racism, and that we also can't try to address this without thinking about family connections and how important they are for many of the cultural groups that are part of our very diverse state. And so we can't just address issues around mental health stigma without thinking about how we're going to engage families. Because for some cultural groups, that's essential. That means that it's also going to need to be culturally competent. We're going to need to have things in multiple languages. So if we have statewide education and contact-based interventions, they're going to have to be certainly in Spanish, but they're probably also going to need to be in Mandarin, and maybe in Yiddish and other languages that are spoken in some of the important communities that we have in our state. And I also made note of the themes around humanization that were coming across in Angelia's statements, and that are super important, that we think about. All of our messaging is going to have to put humanization at the forefront. So contact is not just presenting a face and presenting a story, but it's about presenting a full story that shows a person as a full human that we can identify with. And that means representatives of our different cultural groups, because people will identify with someone who looks like them and has a similar background to them. So we need to have those representatives, very intentionally chosen as we're presenting those stories. And I also made note of what she said about private and public selves. And what I'm hearing there is that we have electeds, we have people in important leadership positions who probably have mental health issues who are not speaking openly about them. And maybe this is the time for them to come out as we roll out these campaigns. So those are the things that I took note of. Sorry if I took longer than.
No, thank you, Phil. Thank you. That's a nice summary of some of the critical issues that were brought up here. And Maria Elena Lecas, I wanted to ask you to sort of come in and sort of give us a little summary of some of the themes that have come across. I know you've shared some of these already, but.
Sure. So first of all, I'm honored to be here today, and everything I have to say was said by all the panelists, if not today in the other 3 roundtables. So very quickly, I'll start with Euphemia, and Euphemia, my saying is, bricks and stones can break my bones, but words can also hurt me. So one of the things we heard is that there are many types of stigma. We internalize stigma, we anticipate it, we expect it, but also we experience it. That's why I'm delighted that Jim put in the opening slide, attitudes, beliefs, and behavior. Because at the end of the day, what we do want to change is how people treat people with mental health challenges and substance use challenges, right? Because people are excluded from jobs, they are deprived of housing. Simca also mentioned even opportunities to get married, right? So I also heard in the other roundtables and today very much so about the stigma of substance use. And here it's a special plea of mine to address the two together. And maybe we should revise our language and start talking about behavioral health stigma, especially since we know people that are often excluded from mental health services end up using substances to self-medicate. So, and this happens especially in minoritized communities. So by not recognizing substance use as an addiction and not recognizing the stigma of substance use, we are adding to health inequities. We also heard very, very loud and clear about the stigma in our workforce, our own workforce, and healthcare services and providers. And here I want to applaud the OMH effort and Suzanne's bravery in conducting a survey about stigma, not just among service recipients, but also critically among healthcare providers and among folks on the leadership level. And I think this is critical. We need to change there what's happening. I also heard that stigma intersects with other statuses and identities we all live with. I applaud Euphemia's use of the word racism, because this is what it is. And I would add to racism, sexism and genderism and homophobia and transphobia. All of these things come together. So when somebody says, a parent, a service recipient says, I feel stigmatized we should consider that this stigma could be coming from other statuses and experiences they might have had even before a diagnosis, even before they had a child with a mental health challenge. It's critically important to recognize intersectionality and adopt this lens. Related to this, and you all spoke about that, it's critical, and especially Daniel, you did, it's critical to recognize what kind of treatments and approaches do we consider evidence-based? Because consider what were the samples, right? What were the folks that were included in these studies where we assessed so-called evidence-based interventions? We do know that racially and sexually minoritized communities were often left out. However, we do know that BIPOC communities have their own ways of addressing mental health issues that we haven't done enough research to be considered evidence-based. So, one of the things we need to look at is that community-based approaches, and both Euphemia and Daniel, you mentioned that, our own communities' ways of addressing our well-being. And in that vein, we should also recognize that communities have strengths and not just to blame them, right? Because we're very fast to blame them. I also heard about the media, and this is, how media can harm and how they focus on catastrophic stories. One of the things I noticed in the third panel with the media is that the journalists still have very much the framework of the personal story. And although, the panel we have was the choir, well-selected people that give a damn about this issue, they still spoke about a person and humanizing the person, right? So that is a problem because they never mention what is happening outside the person. They rarely talk about the family, the community, and society at large. Why is this person on the street? And that feeds into the stories of violence. And I think it's time we decouple, we separate violence from mental health. Not only the media, but I think as a culture, we have included violence as the DNA of what we think of when we think of mental health challenges and substance use challenges. It's almost like we think these conditions and dangerousness and violence. So we have to change the public stigma around that. I know I'm over time. I have two more very quick points. The last one is about one of the journalists, to her credit, spoke about this moment, and Euphemia, you spoke about that as well, this critical moment where we recognize that mental health conditions are ubiquitous. We all suffered through the pandemic. We all suffer through, traumatizing experiences around racism. So I think now she spoke about a moment of revolutionary change. And I think now is the time where we have an increased awareness of racism, genderism, all kinds of isms to engage in what you all spoke about, which is, I think, the most important thing, legislative and policy changes. And finally, I want to honor Simka's point about, positivity. And I remember there was an article many years ago about coping with all kinds of illnesses. And the title of the article was The Tyranny of Positive Thinking. So I think we need to honor families and individuals and communities and recognize when they're suffering and struggling, and not to try and minimize it and focus and kind of beautify it because of our own discomfort, recognizing the suffering. Thank you so much, and I'm sorry for going over.
Thank you, Maria Elena. So again, in the interest of time, I want to move to questions and answers and sort of see if we can get some questions from the audience. In the meantime, though, David, if you can bring up our word cloud and see some of the things that folks have brought up with regards to, oh, here we go. And you did a wonderful job, because I myself, as we were thinking about this activity, I was thinking, well, how do you put one word to solutions? And you all did it. This is an amazing sort of word cloud here. But what's right there in the middle is education. And then, of course, sort of to a lesser extent, empathy, compassion, listening, talking. These are, and again, educate on the side. Advocacy, support, kindness. I'm going to speak up. And I'm just humanize. I see that some folks have used that word as well, knowledge. Does anyone else sort of see anything that they can pick out? And I'm not sure if you could enlarge it a little bit, David, but we have a good sense. I think as we move into questions, I want to pull some out that have been, and actually, so I think the first one, going back to the word wall, we don't have to go back to it, David, but just the emphasis on education, and we talked about the different approaches that are out there. And I'm wondering, from your perspective, both for you all that are on the panel as well as our research experts, what do we know? I think there's some good evidence that shows that combinations, and that's why your approaches are so effective, I think, is because you're using multiple forms of stigma reducing approaches. And so, but what do we know is the most? My understanding is it's some combination of education, contact-based, but what do you all see as the most effective from your experience? And anyone can share, again, researchers as well as panelists. What do you see as the most impactful?
So, I'll be brief, but, because we are in the schools and we have been now for several years, I can say that sort of that collaborative approach of working very closely with schools, with teachers, with students, with administrators about mental health related issues, about anti-stigma efforts are incredibly significant. But I also want to recognize the Office of Mental Health as well, because they've gone through and the commissioner's done a great job in terms of the mental health clinics in schools. I think that's a big piece of this as well. So we're looking at it from sort of a holistic perspective from our end about sort of like capturing individuals who might have some mental health related issues, but also have, feel some stigma around, mental wellness and not getting enough support in their schools. And then you're also having the other piece of this where if somebody is not doing well and needs strong support, and God knows after everything that's gone on after COVID and everything else, that you have this school-based mental health clinics as well. So you are addressing, from our perspective, you are addressing sort of that whole piece around schools. But also to the point of Philip, we have to be more engaged with schools. We've done some work, but we have to continue to do more work and routinize it and make sure that there are specific curriculums about mental health, and that teachers are sometimes stymied in terms of what do we talk about with mental health. And we have to do a better job of going and doing the inreach to the schools around that as well.
Thank you.
I think, thank you, Glenn. I think legislation, right? Legislation frames policies that operationalize at facilities. They set guidelines around workforce incentives, credentialing. They provide frameworks for there to be deliberate integration of education, and they expand services, right? So for us, certainly a combination of all of the things that we talked about, but we say, if we're New York, it's about the people and the policy, and the people and the policy have to go together, right? They have to equate to each other in some sense. Now, that doesn't mean that we can legislate ourselves to all of the solutions, but at least we'll have a leg to stand on if we need to sue. So whatever the case may be.
We have a very relevant issue, and I think I wanted to mention, I believe it's Juan Bui has the question about 988. So as we've talked about culturally relevant services and language and the importance of language and services in different language, 988 is one of the sort of major efforts going on in the country around mental health support. But yes, it apparently only comes in English or Spanish services. And the question is, How do we increase it? I think Dan mentioned it before, the need to increase the number of bilingual service providers as one of those areas that sort of addresses the issue of cultural relevance and competence. I wanted to get folks' thoughts about that as well as, yeah.
No, I wanted to, oh, sorry, there's a bunch of people. Jim, who should talk?
No, you're on, and then Euphemia, because I
Okay,
saw
cool.
Euphemia.
So, if it wasn't already clear, I just really wanted to emphasize that, law systems, institutions really actively harm and disempower communities when these aren't really included. So we really need those empowered to actively utilize their power to specifically target empowerment and community-driven wellness practices. So from that kind of language perspective, right, I think about data, right? And it was only really recent that disaggregation of data about Asian Americans in New York State happened, right? So whereas before there was this lumping together of Asian Pacific Islanders all together, now many different ethnicities are named in any State Department collecting information about ethnicity. And so like that is even where it begins, right? How will this then lead to participation by specific ethnic groups to support their individual communities' needs, right? And at the same time, the label Asian American as a term really grew in the 60s to build political power in our racialized society, right? So there's this kind of like duality associated with, hey, like Asian American as a term is to build power as a cohesive group, as a coalition. But then, hey, like there's so much diversity in our community that many needs become invisibilized. And then as a group itself, it becomes even more invisibilized because then people buy into this myth of the model minority. So we're really thinking about unpacking what it means to support communities is really key from that specific data-driven side, but also like the biases and stereotypes that people have about our communities. And earlier someone like I think Philip, you mentioned like, oh, language access in like Mandarin, right? But like even among the Chinese community, there's like so many different dialects, right? I speak a dialect, Niju, which is not very spoken in New York. When I moved here, like someone's thumbs up, like Kaginang, to anyone. I'm like saying that in front of so many people. This is wonderful. Anyway, thanks.
I just want to take a little switch a little bit. And
I apologize, folks. Euphemia, if you can briefly make one last comment, because then we're gonna
be very brief.
Thank you.
That as providers, sometimes we think we are helping when we're harming, and we continue the stigma by isolating the people that we work from the larger population. When we provide the services, it's only for this specific group of people, and that's it. We cannot break down the barriers, keeping people in silos and separated and isolated from other groups. We have to bring the groups together because it is through interaction with one another, hearing each other, feeling each other's stories and experiences that we get to understand and respect each other.
Thank you, Euphemia. And look, folks, I realize that there's, as I mentioned earlier, be okay with unfinished conversations because this is an unfinished conversation. It is so much more that needs to be covered and said. So I do want to transition because actually there's some really good information that we want to share. So David, if you could bring up the slides. In the meantime, if you'd like, we're going to share a few things, but what we want you all to share, and panelists, researchers, audience members, what gives you hope that things can get better? I know for me, some of the things that I've heard today give me hope. And I'm going to give a shout out to Glenn, especially that work with young people and the importance of addressing mental health stigma, early intervention to some degree is so critical. That gives me hope. But anyone else wants to share in the chat, what gives you hope? And we'll bring it up. In the meantime, just a couple of resources that we have. These resources are available. I believe, David, these resources will be available at Mental Health News Education. So you can you can see the previous roundtables. I know some folks mentioned they would have liked to have seen one of the previous ones. You can at the website, at the MHANYS website. And again, there's another issue. You can view the previous issue of mental health, of behavioral health news, the stigma issue. I got to tell you, it is amazing. It is incredibly educational. And as we mentioned earlier, experts from the field. And when we say experts, we mean researchers, clinicians, people with lived experience, writing stories about mental health stigma. Wonderful issue. And then the New York State Office of Mental Health Resources, publications that they have. And I believe there's information there about the work that's going on that Suzanne's going to talk about in a minute. And then the Carter Center for anyone who wants information about what are the guidelines and how we can hold journalists and media accountable for language. You can take a look at the Carter Center materials around that. And then I'm going to turn it over to, I believe, next slide. So I'm going to turn it over to Suzanne to talk about next steps, because this is critical. We don't want to leave it here. Suzanne?
Thank you, Jim. I'll be brief. We are looking to establish a mental health stigma work group. This is open. We have not done this before. We certainly have our core team of individuals who've been working on the strategic plan and the specific activities there. And we want to expand this and have it be more of a work group that is composed of individuals of all sectors of the mental health community. So if you have any interest, please let us know. There is a lot of OMH funded work taking place about mental health stigma reduction. This work is funded through the anti-stigma checkoff funds. When you complete your New York State income tax returns this year, please check that box at the bottom. You still have an option to make a donation to fight stigma in New York State. That money is accounted for and has been used to fund a lot of the activities that we've done so far. Roundtable materials. We know, Jim and David have both mentioned this website. It's Behavioral Health News, which is part of Mental Health News Education. Just quick flashback or throwback Thursday to our last roundtable. You heard from journalists. Journalists can be reached at this link. They want to hear from us. They would like to take on stories which they think and which we think could help round out the portrayal of people who have mental health challenges and the portrayal of mental illness as a public health problem and opportunity. Media and mental health guidance is being developed. So we will be working on that, using that Carter Center resource as our foundation, and we'll make that widely available. And once again, both David and I mentioned the spring 2023 issue dedicated to stigma. You've got a little more time if you're interested in contributing a journal, an article for that special edition newsletter. Next slide. Just quickly, I want to credit Dr. Karen Wagner, who has worked with each of our 7 community-based organizations who have received mini grants to do anti-stigma work in their communities. Karen worked with each of them to just very broadly portray tops of the trees of the type of work that has been done by each of these 7. Karen, this is beautiful and it's inspiring. Thank you so much. Just a little more detail about those 7 mini grants. Quickly, you'll see as you scan the next 2 slides, and David, thank you for showing these, you'll see that we have representation from each of the 5 regions of New York State. There are 7 awardees, 3 doing great work in New York City, and the remaining 4, 1 in each of the remaining regions of our state. We've got Hands Across Long Island. We've got Integrated Community Alternatives Network in the central part of our state, Montefiore Medical Center and Columbia University partnering in Manhattan, NAMI NYC partnering in Manhattan, and we highly recommend that you check out all of these agencies and spend a little time taking a look at the video that's linked there by NAMI NYC. Next slide, please. SUNY Downstate in Brooklyn, United Way of Dutchess Orange Region, and Yates County out in Western New York, who've done some beautiful bus wraps and billboards. Not trying to leave anybody out. I just know we're at our time and appreciate, David, you walking us through these last few slides.
Thank you, Suzanne. And with that, I think, again, this was an opening discussion. These 4 roundtables have been incredibly educational and inspiring. And so I want to thank you all for participating in them. I want to thank OMH and the Mental Health News Education for sponsoring these. I want to thank our panelists, amazing panelists. This was an incredible panel today with so much information. And I hope inspirational as well in providing hope to many folks. And lastly, I want to thank you, the audience, because I think your participation, the registration numbers and the participation on these calls has really demonstrated to us all, and I know to Suzanne and the folks at OMH, how important this issue is to the community and folks in New York State. So I want to thank you all for participating in these and joining us, and know that this is not the end of the discussion. This is the beginning of the discussion, and we hope to include you in more activities in the future. Thank you all so much.